know. However, patient-reported outcomes have generally been positive. And those of you who've had the procedure, or that you heard, and actually Dr. Duncan mentioned these, fatigue better, quality of life, cloud lifting, pain better, stiffness, and basically I just feel better. And this has been helpful to me. But the objective neurologic data is scarce, and that's why I'm so proud of the Hubbard Foundation for some of this work that they're doing. They're just giving us objective findings. There's been 2 deaths reported, and one stent got dislodged and went into the heart. And those are well known. But what's not well known is what happened to the other 15,000. I'd like to know what happened to the other 15,000. I want to make sure they're okay. Because people who do well tend to talk about it. People who don't do well don't talk about it. And the follow-up and reporting are so poor in many centers, not all centers, but many centers, it's really poor, that adverse events I think are going to be missed. So let's stop that. There are ways to stop it. So what do we need to do? Okay, so what are the needs here? Well, before treatment, got to make sure they have MS. There has to be a specific criteria for, does this patient have MS? You say, well, of course everybody has MS. Why would anybody have this procedure if they didn't have MS? Well, I can tell you, they do. They may have Alzheimer's disease, they may have Parkinson's disease, they may have all sorts of other things. Or they may have psychological problems. And that 1 out of 9 patients who comes on MS Center does not have MS when they're diagnosed with a board-certified neurologist. In my practice, it was 1 out of 3, because I saw really tough people. So be careful about making the diagnosis. And I don't see how, I have trouble, I don't see how the interventionalists can make the diagnosis. They've got to have neurologic diagnosis. And then the diagnostic accuracy, I'm not going to go into this. Dr. Hagee could talk about this. But you got to have an accurate diagnosis. And then you have to have objective neurologic findings. And these are some of the things that we do to test that neurologists would believe. And frankly, lifting of the cloud actually may be very important. But neurologists need something else besides patients feel like their cloud is lifted. And we need standardized patient reporting outcomes before and after. In other words, we need to have objective findings before and at various times after. And you can do this with the tests that are being developed. And these are subjective tests because they're how patients feel. But before and after is going to be very important. It's going to increase the validity. We need standardized treatment protocols. You know, how do you, angioplasty is done, is not angioplasty, is not angioplasty. Stents is not stents. There are different ways of doing this stuff. So we need to have some uniformity here. And there's also valvular defects. It's not necessarily stenosis, but there are valvular. Dr. Dake is going to talk about this. But almost every interventional surgeon or radiologist who's done this says, I'm surprised. When we get in there, we'll be fine. It's not what we expected sometimes. So we need standardized protocols. We need competency of the facilities. We need people who know how to do this, who have experience doing this, and that they have institutional review boards, and those institutional review boards are standardized. We need well-defined control groups. We need somebody else to compare these patients to. And I know Dr. Dake is very interested, and he'll talk about placebo controls as well. Is it legitimate to do placebo controls in patients with multiple sclerosis with a liberation that we know works? The answer to that is no. But a liberation that we don't know whether it works or not is actually very legitimate. And many of the trials in drugs, now we have like 8 FDA-approved drugs. We still do placebo-controlled trials on new drugs because we think it's that important. And we need consistent follow-up. I cannot emphasize this enough. We need medical follow-up. These people get anticoagulants. We need somebody got to take care of them. How many people have had this procedure and then they go home and they say, well, nobody's here to take care of me. What do I do if I have problems? We need a follow-up on are the veins patent, and obviously we need neurologic follow-up. And we need a reporting of adverse events, and I think that's going to come from a registry. All right, let me give you the summary. Let me summarize this. The results and opinions vary, and even the same results can be interpreted differently. Dr. Zamboni, there was a paper that says this doesn't exist. And he then wrote an impression that, in fact, their data proves it does exist, because he reinterpreted their data for them. It's very confusing to people like me who don't understand this stuff. Patient-reported outcomes are generally positive and objective neurologic data is scarce. You gotta have both. Neurologists and interventional doctors are not working together to get to the bottom of the issue. And that's really our problem. And we need to stop that. We need a collaborative effort here, and I'll talk about that in a minute. Standards are not established. There's a lot of variability. And it may not be the cause, but it may actually be something that develops afterwards. Angioplasty procedures are subject to restenosis. So it isn't like you have one test. You have one angioplasty, one liberation, and you're liberated forever. You may have to come back, and stents may be hazardous. I'm going to repeat. This is what the interventionalists say about this. It's inconclusive. And I hope I've given you enough data to show you that don't be mad at your neurologist, because neurologists are only interpreting data, and you've seen the data, and how would you interpret that data? You're lay people. I'm sure that the vascular surgeons and interventional radiologists group are saying, yeah, I can understand now more about how the neurologist might think. Okay, so what do we do? So I believe what we should do is we should prepare a united message, all of us, a multidisciplinary international task force to really look at the state of the art of 2011. What do we really know? What do we only think we know? Because we think we know a lot. But then we're going to actually look at that as what do we really know? And then where are the gaps and how we can fill the gaps? That's what we need to do. We need direction and where to go. And who needs to do that? Well, we need to have people sitting at the table from all different areas of expertise. The MS people, the interventionalist people, the diagnostic people, the scientist people who want to know a lot more about iron than I do, or blood flow, and have the immunologist there and say, is this an immunologic issue? And we also need the patients there. Because the patient organizations, the patient advocacy organizations are going to be really important in providing information to patients. Because these reports tend to be very technical, nobody understands them. We need something that's understandable. All right, other next steps. We need to define what's the best diagnostic test and what outcomes are we looking for. We need the treatment standards and we need outcomes. We need to define what is success. That's what we need. What is success? We need to make sure that the diagnosis of MS is made before the procedures. And we need to make certain that the people who are doing these procedures and the facility they're having done in know what they're doing. And again, that's a doctor's problem and a hospital's problem, but it's really important to do that. And we need to define what an IRB requirement. Institutional review boards are patient safety boards. So nobody should have this, in my opinion, if they don't have a patient safety board looking at it and saying, yes, this is a safe thing. So they understand the benefits and the risk. All right, follow-up here. We've talked about that. I won't go into it, but we need all four of these people saying, this is what you need to do to follow. And you don't do that after the procedure. You do that before the procedure. Your follow-up needs to be defined before you have the procedure. And I know that happens at the Hubbard Institute, and I wrote that happening all over. So when you retreat, what procedures do you use? If you fail angioplasty once, do you get stents? Twice, 3, 4, 5? What do you do? Give us some guidance there. It's when you use stents and when you use angioplasty. And the registry we've talked about. The registry can help us talk about outcomes, adverse events, retreatments, and other data that may be important over time. And so we want to articulate the balance between benefits and risk. And we need this document in lay terms. We need two versions. The science versions so the neurologist can be satisfied, but we need patients to understand what this means. My last slide are my final thoughts. I've tried to represent the neurologist. I've been wearing the neurologist hat. Now I'm going to tell you what I think personally about this. Like the Society of Interventional Radiology, I don't know the relevance of CCSVI to MS. I don't know if it's positive or negative right now, but I know that there are questions that can be answered. We know what those questions are, and we have ways to address them scientifically. So I have great hope that with the new research that's going on, with the people in this room, we're going to be talking to you, and next year we'll have a lot more information to understand the relevance. If it's not the cause, if Zavadanov's impression is right, that it comes afterwards, not before, so it's not the cause maybe,